Hello everyone, myself Spurti, studying second year MBBS in KRIMS Karwar. Today I will be discussing on the topic graft rejection. Firstly, we will know what is transplantation. Transplantation is the process of moving cells, tissues, organ from one site to another, either within the same person or between a donor and a recipient. The immune system plays a critical role in transplantation. The complex mechanism of immunity, which under normal circumstances work to identify foreign microbes and direct the immune system to destroy them. What is graft acceptance? Immune system do not stimulate the immune response against all the antigen present in the graft, and no graft rejection even when the donor and recipient are not synergic. So now we'll discuss the topic, that is graft rejection. So what is graft rejection? Basically, the process of rejection of the graft in which the recipient's immune system recognizes the graft as being foreign and attack the graft, leading to graft rejection. Mainly, the graft rejection involves two types of rejection. First one, cellular mediated rejection, and the another is antibody mediated rejection. This is the diagram depicting mainly the cellular and antibody mediated rejection, where here the cellular rejection mainly involve CD4 cell and also antigen presenting cell, whereas the antibody mediated rejection mainly includes the alloantibody production, also interleukin 10. So we will now discuss in detail about the cellular and antibody mediated rejection. Cellular mediated rejection. This rejection is mediated by lymphocytes that have been activated against donor antigen, primarily in the lymphoid tissues of the recipient. The donor dendritic cells enter the circulation and function as antigen presenting cells. Destruction of grafts occur by CD8 plus CTLS and CD4 plus helper cells. There are two types of pathways involved in cellular mediated rejection. Firstly, direct pathway, and another one is indirect pathway. So we will now discuss about the direct pathway and also about the indirect pathway. In case of direct pathway, it is an acute graft rejection where there is a recognition of self versus non-self cells. Here, the T cell recognizes alloantigens. The T cell also stimulated by APC, that is antigen presenting cells from the donor. T cell activation and proliferation occurs in direct pathway of cellular mediated rejection, whereas in case of indirect pathway, the T cell recognizes foreign antigens from donor. The recipient antigen presenting cells present these antigens and also leads to the proliferation. This is the diagram depicting mainly the direct pathway and also the indirect pathway, where the antigen presenting cell in the graft is mediated by MHC1 and MHC2. Further, it processes and also gets damaged or apoptosis. Next, antibody mediated rejection. Antibody mediated rejection, it defines all allograft rejection caused by antibodies directed against donor, specifically HLA molecules, antibody molecules, also blood group antigen, ABO, isoagglutinins or endothelial cell antigen. It is also called humoral rejection. It consists of mainly three types, that is hyperacute, acute and chronic rejection. Here is the diagram completely explaining hyperacute, acute and chronic rejection with different subheadings. Mainly, hyperacute occurs within minutes to hours, whereas acute rejection occurs within days to weeks and chronic within months to years. Hyperacute is mainly mediated by preformed antibodies against donor antigen, whereas in case of acute it is T cell mediated along with the antibodies, whereas in case of chronic it is patchy infiltrates and cardiomegaly. We know that hyperacute is irreversible. Acute is often reversible with immunosuppression, whereas chronic is usually progressive and irreversible. The key features are immediate graft failure in case of hyperacute, cellular infiltration and graft dysfunction in case of acute, and chronic graft vasculopathy in case of chronic. So, the main reason, the pathology between all these graft rejection are thrombosis and ischemic necrosis in case of hyperacute, and interstitial inflammation vasculitis in case of acute, and intimal thickening and fibrosis in case of chronic. Now we will completely studying hyperacute, acute and chronic separately. Antibody mediated rejection. Here firstly hyperacute. It is caused by the presence of pre-existing antibodies of the recipient that match the foreign antigen of the donor, triggering an immune response against a transplant. Acute. It will occur in all transplantations except between identical twins. Acute rejection is caused by the formation of antibodies following the detection of non-self antigens in the donated graft. Whereas in case of chronic, it is a repeated episodes of acute rejection can ultimately lead to chronic rejection of the graft and failure of the transplant. So, the time course of graft rejection, as we seen in the previous slide, hyperacute rejection occurs within first 24 hours, whereas acute rejection occurs within first few weeks. But last, the chronic rejection occurs within months to years. So, this is a diagram completely depicting the hyperacute, acute and chronic rejection, how the endothelial cells undergo changes. Now, hyperacute graft rejection. The preformed antibodies specific for the antigen present on graft endothelial cells, resulting in the rejection of the transplanted organs within minutes to hours. The preformed antibodies may be natural IgM antibodies specific for blood group antigen, or it may be also the antibody specific for allogenic MHC molecules that were stimulated by prior exposure to allogenic cells because of blood transfusion, pregnancy or transplantation of another organ. So, the hyperacute rejection is rare nowadays since the donor and recipient pair is matched for blood type, and also potential recipients are tested for antibodies against the cells of the prospective donor with the cross-match test. When after the graft is transplanted, there occurs a blood flow. Blood flow is restored where the antibodies binds to antigen on the graft and graft of vascular endothelium, which activates the complement system. This leads to rapid endothelial injury, thrombosis, vascular occlusion and ischemic necrosis of the graft. This is a diagram which explains the complement activation, inflammation and thrombosis, where the endothelial cells of the graft are being rejected. Here, mainly because of pro-inflammatory cytokines, neutrophil recruitment and also the platelets. Acute graft rejection. It is mediated by T cells or antibodies that are activated by allo antigens in the graft. It occurs within days or weeks after transplantation. It is the chief cause of early graft failure. It can appear much later after transplantation when the immunosuppression is trapped or terminated. Acute cellular rejection. It is mediated mainly by CD8 plus CTLS or CD4 plus T lymphocytes. The CD8 plus CTLs may directly destroy graft cells, whereas CD4 plus cells may secrete cytokines and induce inflammation, damaging the graft. T cells may also react against graft vessels, leading to vascular damage. Whereas acute antibody mediated rejection, it is mainly mediated by antibodies and targets vascular endothelium. Antibodies bind to vascular endothelium and activate complement through classical pathway. The resultant inflammation induces endothelial damage and results in graft failure. It is a diagram. It explains how alloantigen specific CD8 plus and CD4 T cells work in graft rejection. As I told, CD8 mainly act on the cells, whereas CD4 cells mainly secrete the cytokines which recruit macrophage and neutrophils and helps in graft rejection. Chronic graft rejection. It is a form of graft damage mediated by cell-mediated immunity. It is a form of graft rejection mediated by cell-mediated immunity that occurs over months or years, leading to progressive loss of graft function. It manifests as interstitial fibrosis and gradual narrowing of graft blood vessels, and this is termed graft atherosclerosis. The activated T cell react against graft alloantigens and secrete cytokines, which stimulate the proliferation and function of fibroblasts and vascular smooth muscle cells in the graft. In a small fraction of cases, alloantibodies also contribute to chronic rejection. It's a diagram which mainly helps in depicting how the chronic graft rejection occurs. We can see the chronic inflammation as the intimal smooth muscle proliferation and occlusion of blood vessels due to the chronic inflammation. It is mainly because of antigen presenting cell CD4, where it also releases the cytokines. Multiple events take place and resulting in the inflammation of the blood vessel. Thank you.